practitioners, I will try to give some background, because that is very much needed to understand that what we were trying to do during the COVID-19 pandemic. I will start with the definition of phenotype, which is a set of observable characteristics of an individual resulting from the interaction of its genotype with the environment. So it means in our terms that the phenotype is determined by the host genome, and the host interaction with the pathogen or with the insult that we are experiencing will lead to some really significant observable characteristics. And the phenotype can be hair color, it can be eye color, it could be the length of the tail of the dog, which is all determined by the genotype and its interaction with the environment. So that's where the whole phenotype question comes around. Now, history does repeat itself, especially if we are not aware of it. And history of ARDS and the acute respiratory failure has been a long story, which is a long story of trying to phenotype a syndrome, which is quite difficult to phenotype, because we haven't really understood what is happening. The first presentation and the first real scientific description of acute respiratory distress in adults was done by Asbaugh and colleagues in the US in 1967. So that was 53 years and exactly 1 month ago that they published this paper in The Lancet, where they described 12 patients who had a significant cyanosis. They had significant dyspnea, oxygen requirement, and they have been characterized by what they described a striking feature of bilateral pulmonary infiltrates on the chest X-ray. The first description of these 12 patients was really interesting, because this was done in civilians and already pointed out that acute respiratory distress, or ARDS, which is got called, is a syndrome. In this paper, there were a couple of patients after multiple trauma, some after blunt chest trauma, some after gunshot wounds. There were 3 patients with viral pneumonia, and there were a couple of patients with other illnesses. Interestingly, in this very small cohort of 12 patients, what they found is that positive pressure ventilation was associated with really good outcome only if it was done via what they described as a volume controlled mode. So where they controlled the volume which was delivered to the lungs, and not in those ventilation types where the pressure was determined. What they also noted that in patients, especially those who had viral pneumonia, the use of corticosteroids was associated seemingly with a better outcome. And they have noted that if they gave corticosteroids to patients after trauma in this circumstances, then it actually worsened the condition. So a very early description of acute respiratory distress has already opened the door to see that it is a big syndrome and it cannot be described very easily. Now, during the last 53 years, there were at least 4 different definitions of ARDS, and it has been a very difficult path. The definition of ARDS has, well, the 4 definitions of ARDS, which have been evolving sometimes parallel over this time, they were all concentrating on the phenotypes or on the findings of the original Asbach paper. So they were looking at bilateral pulmonary infiltrates, significant hypoxemia, in the absence of cardiac failure. And that has led to trials which were trying to improve the outcomes of these patients. It has been recognized that that the ARDS definition is difficult. So in 2012, a consensus conference in Berlin devised the Berlin definition of ARDS, which is currently the gold standard for that. The Berlin definition actually changed the path from the previous definitions, because it characterized the syndrome according to the hypoxemia, which was described by the PaO to FiO2 ratio, so the arterial oxygen tension divided by the fraction of inspired oxygen. And also, this was the first definition which actually clearly and quite explicitly described the chest X-ray and CT findings which could lead to ARDS definition. So since 2012, the major studies which are looking at types, diagnosis, phenotypes, and treatment of ARDS were utilizing this definition. And we have seen that although it is difficult to characterize the syndrome, the trials are seemingly trying to get the right patients into that. So the question is it a really big problem? There is a lot of debate that how prevalent ARDS is in the critical care units. And some even say that ARDS can be quite prevalent outside of critical care. There was currently the largest multi-center, multinational observational study by Giacomo Bellani and his colleagues, which was published in the JAMA in 2016. In 2014, the study looked at patients who had been on the intensive care unit. They were on mechanical ventilation, either invasive or non-invasive mechanical ventilation. They have been hypoxic, and they looked at who fulfills the Berlin criteria. And depending on the setting, 7 to 11% of the ventilated patients fulfill this criteria. In 2017 and 2018, we did a much smaller but still multi-center study on the Welsh ICUs, and we found that actually in our patients in Wales, it was less than 3% of patients who were needing mechanical ventilation who had ARDS. The hospital mortality of the syndrome is in the region of 40%, and that is very similar to Wales. And unfortunately, it is largely unchanged despite the 53 years and 1 month past since the first publication. So it is still a difficult problem to treat. The ARDS phenotyping came from the realization that the clinical characteristics of the syndrome are probably not enough to describe what is happening with these patients. And with the advent of immunological monitoring and cytokine monitoring. There were larger data sets present in different clinical trials, which paved the way to look at a very detailed and slightly complicated analysis called latent class analysis to try to classify patients with ARDS into different subtypes. And what you can see on this picture is the proof, as it is, that these ARDS phenotypes are existing, and they are actually existing over time. So this study by Professor Dellucci and his colleagues were looking at two randomized controlled trials and looking at the detailed data from those two randomized controlled trials, where they found that there are two very different classes. One class where there is a lot of inflammation going on, so interleukin 6, interleukin 8, TNF receptor 1 was very high, whereas it combined with a lower PaO to FiO2 ratio and lower bicarbonate, compared to the hypoinflammatory phenotype, where these values were, the inflammatory markers were lower, and seemingly that led to, or that was associated with better PaO to FiO2 ratio, better oxygenation. What they have found that these classes remained the same even on admission to the ICU, so day 0 of the diagnosis, and day 3. And this will become a little bit important further on, because it seems that these classes stay at least for the first part of the ICU presentation. What the group of Caroline Calfee and Professor Dellucci did in a number of different studies where these inflammatory cytokines were available, so they can use this latent class analysis to phenotype the different patients into the different classes. They have looked at whether the hypoinflammatory and the hyperinflammatory phenotype predicts response to treatment. And one of the latest results of this have been published earlier this year in the Lancet Respiratory Medicine, where Pratik Sinha and his colleagues found that indeed the hypo and hyperinflammatory phenotype responded differently to simvastatin in the HARP-2 study. The HARP-2 study was trying to see if simvastatin is actually helpful in reducing the inflammation and improving outcome. And overall, the study, like many ARDS and sepsis studies, were negative. But when you look at the different phenotypes and when you classify the patients into hypoinflammatory and hyperinflammatory phenotype, it does look like that this predicts the response to the treatment, and it actually changes the survival probability whether the patient was treated with simvastatin or not. So this was the first thought that, okay, this phenotyping and the phenotype being an inflammatory response to a insult might be very important in ARDS. Pratik then went on and looked at whether we can define, or he can define, a much simpler model for phenotyping the ARDS patients, because as you have seen in the previous slides, the the latent class analysis used a huge range of inflammatory variables, clinical variables, etc. That is not feasible to collect. That much information is not feasible to collect at the bedside. So they have been looking at whether they can use 2 or 3 or 4 classifiers to get to the same result and to put the patients into the different phenotypes. And what they have found, and you can see it in this picture, again, this is in the same publication, that there were a 3 classifier and a 4 classifier model, which actually determined whether the patients were in the hypoinflammatory or the hyperinflammatory phenotype in ARDS. So it is possible that you can use smaller data sets and less variables to classify the patients. Now, this was all going well, and this was really interesting in general ARDS, which is caused by a variety of problems. But then COVID-19 came, and this is just a graph from our own hospital where I work in the Royal Gwent, where you can see that we had 1 and then 2 and then 3. And then a number of COVID-19 patients arriving at once, and at one point, almost 20% of the patients in the hospital, they were on the intensive care unit with COVID-19, and this has actually put a really big focus on what is happening in ARDS. In March, we didn't know a lot about COVID-19. And in March, in this paper, which was published on the 16th of March, based on a small number of cases, mostly coming from China, it was postulated that a lot of patients with COVID-19 might have what we call a cytokine storm, or something which resembles hemolymphocytic lymphocytosis, which is a well-known immunological disease, which does correspond with a lot of cytokine release, a lot of inflammatory problems. And in this paper, in this letter to the editor in the Lancet, Mehta and colleagues raised the possibility that this cytokine storm is indeed important in COVID-19, and maybe we should use some immunosuppression. Now, as I said, in March, we did not have a lot of information about COVID-19. We haven't had anything to base our treatment on, and we were all scrambling for some information. So this was when this paper got published, everybody started to look for the HLH phenotype, and when you put into Medline now that COVID-19 and cytokine storm, well, at least at 4 o'clock this afternoon, there were 993 publications which were talking about this problem. So, what could we do? Fortunately, we had an ongoing research effort in March. We were and we are participating in the FIND study, which actually looks at 2 cytokines and 1 other biomarker, bicarbonate, to try to classify the patients into the hypoinflammatory and the hyperinflammatory phenotype in ARDS. In Newport, we have been very lucky because we had ample supply of the kit. And when I spoke to Danny McCauley, who is the chief investigator of the FIND study, I think it was on the 14th of March, as we started to see more and more patients, we agreed that we should use the COVID-19 cohort and see whether phenotypes in COVID-19 are generally similar to the phenotypes in normal ARDS. So we started this study, well, continued the study because we have been recruiting to that before. And just to give you an idea that what it entails, as I said, it's a 3-variable classifier, and it gives you the probabilities of phenotype assignment. It looks at IL-6 levels, soluble TNF receptor 1 levels, and serum bicarbonate. The cytokines are determined by a point-of-care assay, which is on the Randox evidence multistat platform. So they are actually quite easy to determine. You don't need central lab facilities for that. You just need the right cartridge and the right assay. So the paper was published on the 16th of March, and on the 17th of March we recruited our first patients into this study. The last recruitment was on the 24th of April, so we were still pretty much in the height of the pandemic, and we had 28-day follow-up for the patients. And in our study, we had 39 patients, 32 from the Royal Gwent and 7 from UCLH in London, who were our collaborators. And we have published our results in the Lancet Respiratory Medicine now a couple of weeks ago, and we have tried to describe the prevalence of phenotypes in COVID-19. Our patients, they all fulfilled the Berlin definition of ARDS. They were all significantly hypoxic. Actually, they all had classic chest X-ray or CT changes, so they would have fulfilled the original ASBA criteria for acute respiratory distress, and they were really representative of the UK critical care population at the time. This is just an excerpt from the table from the paper to show that the total population was closely aligned to what we have seen in the UK elsewhere in terms of age, the sex distribution, race distribution, and that these patients they were seriously unwell with low oxygenation. We needed to ventilate them with high plateau pressures, with a high positive end expiratory pressure, and generally you can see from here in this this line that the compliance was low. The normal compliance of the lung should be in the region of 90 to 100, whereas the compliance of our patients was generally in the 20s or at maximum low 30s. And they've had remarkably normal other blood results on admission to ICU and on admission to the study. The patients were recruited early, so most of them they were recruited on the day of admission to the ICU, always within 24 hours of the ARDS definition, and the blood samples were taken within 2 hours of the recruitment. So we tried to be as quick as possible. We looked at a large number of inflammatory markers, not just the ones that we measured on the cytokine assay, and you can see in this this graph that there were some correlations with the the different inflammatory cytokines. So, for instance, LDH and procalcitonin were closely correlated, as expected. C-reactive protein and procalcitonin were closely correlated. But there was nothing really striking. These correlations were, when you do a statistical analysis, they were relatively weak, because you would expect a much darker blue if the markers are really going side to side and hand in hand. So it looks like that there is some general inflammation, and the markers are going together, but that was not very striking. When we looked at the hypoinflammatory and the hyperinflammatory phenotypes, we used the IL-6 TNF1 receptor and bicarbonate as the classifier, and we have used two different cutoffs. In the paper, we have described the lower cutoff, which meant that the hypoinflammatory phenotype, that population contained 31 patients, and in the hyperinflammatory phenotype, there were 8 patients. Those were the patients who had really higher inflammation present at the time of admission and the start of the ARDS. They were well measured. They were well measured with clinical parameters. As with previous studies, the hyperinflammatory group had slightly higher APOE2 scores. The other variables were fairly comparable. We had slightly lower creatinine in the hypoinflammatory group and slightly lower LDH, but for instance, the lymphocyte count was comparable, and there was no statistical difference there. We have compared our patient population to previous ARDS cohorts, and again we got lucky, because in the HARP2 cohort we not only had 39 patients who were matched with the clinical parameters to our COVID-19 cohort, but also those 39 patients, they had their inflammatory cytokines measured on the same Randox multistat system. So they were completely comparable. So the numbers were completely comparable. The method was completely comparable. So we could see what difference there is between the two cohorts. And you can see that one of the biggest differences here is that in the HARP2 and the HARP2 mesh cohort, the mortality is in the region of 1/4, whereas in the COVID-19 cohort, it was above 44%. In the hyperinflammatory phenotype, in the HARP2 and the HARP2 mesh cohort, the mortality was in the region of 20%. It was almost double in our hypoinflammatory cohort, and I wouldn't put too much emphasis on these numbers because the numbers are so small, but at least comparable mortality in the hyperinflammatory cohort. When we try to compare our patients to the previous cohorts, we have found that our patients had lower APOE2 scores, which is expected, because we have seen that the COVID-19 patients who came to the ICU, they generally came and started off with a single organ lung failure. They were not shocked. They didn't have renal impairment at the start of their journey, whereas in the previous ARDS cohorts, that was a relatively ongoing feature. The other thing that we have seen is that they were comparable in terms of their IL-6 response. They were comparable in terms of their creatinine, and there was a statistically significant difference in the platelet count. Our cohort had higher platelet counts, again just signifying that they were in single organ failure as opposed to multi-organ failure. So what does this all mean, and what are these results tell us? I think the first important statement is that the cytokine storm is not a category 7 storm. It is more a breeze than a storm. There is some elevation in the inflammatory response in COVID-19, but it's certainly not the HLH type really massive inflammatory response that was feared to happen in a large number of patients. What we also have seen is that the hyperinflammatory phenotype of ARDS is uncommon at the start of the ICU admission in COVID-19 ARDS. So we have looked at that group, and the numbers are really small. What I can tell you is that hyperinflammatory phenotype was really associated with a concurrent bacterial infection as well. So maybe that gives some pointers for the future. Very importantly, the hypoinflammatory phenotype, which was very similar in clinical features, actually it had a lower predicted risk of death compared to the sort of historical ARDS cohort. The hyperinflammatory phenotype in COVID-19 has had a much higher mortality. And this again just underlines that this is a new disease, and it is quite possible that the mortality is higher because we need to understand what is going on, and we need to see what are the possible treatment options for this condition. So is this cytokine breeze something which is supported by the literature? And just a couple of days ago, well, actually 9 days ago, this paper from the Netherlands was published in the JAMA, which compared COVID-19 ARDS, sepsis patients with ARDS, sepsis patients with no ARDS, trauma, and out-of-hospital cardiac arrest patients. And you can see that the various inflammatory cytokines, so TNF-alpha, IL-6, and IL-8 concentrations are generally lower than the sort of classic ARDS cohort, which is due to sepsis, but at least comparable to previous ones. So I don't think that there is such a storm going on here. There is always a question that can it change over time? And then in this really elaborate and very nice paper from my really good friends, Manu Shankar-Hari's lab, we have seen that there are some bumps on the road from days of symptom onset, but generally the different inflammatory markers, they are the same, probably the highest at the time of ICU admission, and then they are going down. So probably the classification on day 1 ARDS will stay with the patient for during the length of the ICU stay, as we have seen it previously in the classic cohort. What does this all mean? Our results show that the point of care determination of cytokines is feasible. We have done it. We have run the tests within 2 hours of recognizing the problem, and we didn't have any glitch. And it may be used for directing therapy. Why I say may be used, because the whole steroid business, which is currently the only proven treatment for COVID-19, is still unclear that which group of patients are really benefiting for steroids. Can we use this data that we have produced to try to pinpoint the phenotype which is better fed if they give steroids? There is a lot of controversy about it. As I said, our hyperinflammatory patients, they had a concomitant bacterial infection. Corticosteroid use in pneumococcal pneumonia actually has increased the mortality. So it might be counterintuitive, but it could well be that it's the hypoinflammatory phenotype which will benefit from steroids more. We don't know. We need to have a lot more data, and we need to have a lot more data to correctly identify the phenotypes, because the previous phenotyping was done, as I said, with the latent class analysis, which is extremely data hungry. But there are international registries, there are international studies which are using very similar definitions. They are using the same immunology and cytokine determination platforms. So I hope that that in the coming months we will be able to put together an analysis on a much larger scale and come to a better conclusion. And finally, I would like to thank my colleagues, well, everybody who has helped me to get this paper over the line. But I especially like to thank Aneurin, who is the awesome R&D manager in Aneurin Bevan, who made possible that this work has continued and is continuing. Shiny, our excellent research nurse, who we have spent a lot of hours together doing these assays. Pratik, who is one of the assistant professors in Wash U in the US and is the first author of the paper and provided the expert advice on phenotyping. And last but not least, Danny McCauley, who allowed me to lead on this really exciting project, and we are working together to make it even more exciting. And with that, I would like to thank you for your attention.
Thank you so much, Professor Tamas, for such a comprehensible presentation with such extensive use of scientific research to back the arguments, also providing your perspective on top of on the topic of COVID-19 and the phenotypes. I thought that was like extremely interesting about the cytokine storm, and things that people, I believe all the participants here didn't think about some aspects of the disease before, and now they actually realized with your research that things that we thought before weren't actually true. So first of all, I would first like to ask, if people want to do some further reading on this topic, what would you suggest them to do?
So I think if there are so many aspects of this work. The phenotyping is one very important aspect, and I think the best literature is in our papers reference list, where we have I think we have cited all the papers which are dealing with the phenotyping of ARDS. So that would be one. That leads on to, unfortunately, current medical research is you cannot understand it without some statistical knowledge. So you have to get your head into the statistic books and understand that what latent class analysis, for instance, means. There are excellent and very down to earth and easy to use webinars on these topics. And I would suggest that that you look for Frank Harrell's series of webinars, and he's got a free online statistic course, which would give an excellent grounding on this, but it's hard work. There is no escape from that with the expansion of the data, we need to have a better understanding that how we can describe that data and how we can sort that data. If somebody is interested on what are the treatment options in COVID-19, I think there are a couple of really good editorials and viewpoints, both in JAMA and in Intensive Care Medicine, published in the last couple of days, which will give you an overview of what is known currently or about this disease. Another excellent resource is the CHEST webinars. The CHEST is the American College of Chest Physicians Society, and they've got at least monthly free webinars where experts are talking about the COVID-19 topics. The previous ones are available for download on YouTube. That is another excellent repository.
Perfect. Thank you so much. We've had a question on the chat box. And by the way, all the participants can drop their questions on the chat box on this webinar. The question is, how did you get the necessary ethics operational permissions to do this so incredibly quickly? And by the way, well done on getting them.
Thank you very much, Judith. This was one part of our luck, that the FIND study was already operational in our unit, and the FIND study was, we have been already recruiting patients to that, and we Danny applied to the ethics committee so we can recruit COVID-19 patients, and the approval, like with any other priority study, came really quickly.
Great, perfect. I also had a question privately about the future steps for your research. Are you going to continue working with COVID-19 and phenotyping? What are the future steps that you're planning to take?
Thank you very much. It looks like that it's inevitable that I will be working with COVID-19 as the cases are sadly increasing, although we haven't yet have a new admission to our intensive care unit. We certainly want to continue with the phenotyping work, and when we will have patients in the second wave, then we will attempt to recruit them into the study. The other aspect of this is that the FIND study hopefully will be open again in a larger number of centers, so we will have more patients, and I'm extremely interested in to see if with this observational data, can we pinpoint a population who might be better served with steroids or with anti-interleukin-6 agents, because that would be the real excuse me, that would be the real benefit of this rapid point of care testing, that I can actually assign the patients into a treatment group, which is really beneficial for them.
Mm-hmm. Perfect. We had another question on the chat saying, we have seen patients from ethnic and black minority suffered severe disease than from other groups. Any phenotype differences that explain that?
Not from our data. not from this data, and especially I think it's not from our data, because our numbers on of patients with ethnic minority were relatively small. Having said that, we had a lot more patients compared to the Welsh national average. So we have seen that that the disease affects them more. Actually, our paper, which I put up, which is going to be published in Frontiers in Medicine in the next couple of days, is looking at the interplay between ethnicity and social deprivation of this patient group, because it might not be just ethnicity; it could be social deprivation combined with ethnicity, which is the real big problem. But from this data set, we haven't seen that. I don't think, as far as I understand, there was no specific investigation for this question previously, but it's certainly something that I will take up with Pratik and Caroline Calfee, because there might be something.
Yeah, for sure. We had another question about with the knowledge on the phenotypes, which group of patients would benefit more from anticoagulants and steroids?
So I was trying to allude to that at this moment we don't know. If I can speculate, and this is all speculation, so don't base any treatment options on this. It might well be that it's the hypoinflammatory phenotype which will benefit more from steroids, because those patients, although they are hypoinflammatory, inverted comma, they still have an increased inflammatory response. And the glucocorticoid effects of steroids are seemingly helping with that group. As I said, we know that in patients who have got pneumococcal pneumonia or any other gram-positive pneumonia, in previous studies, those patients had higher mortality when they were randomized into the steroid group. So although it sounds counterintuitive that the hyperinflammatory group might not benefit from the steroids, this is possibly a scenario, but we need a lot more data to say that. With anticoagulants, again, we know that anticoagulation might help, and that there is a thrombotic event, especially at the capillary level, not in the major vessels, but at the capillary level. Again, maybe in the less inflamed group, these strategies work better. But first of all, I think we need to establish whether anticoagulation and different levels of anticoagulation are actually making a difference, because that is pretty much like my slide on the cytokine storm. It was postulated that it might happen, and then everybody jumped on a bandwagon, and it seems like that it's not the case. So the remap-cap study is actually looking at this question currently, whether full anticoagulation or moderate anticoagulation is better compared to prophylactic anticoagulation.
Okay, very interesting. All of this is so interesting, and thank you so much for sharing this with us. We had another question about, okay, we had a lot of people also thanking you for this excellent presentation. And the question says, does FAR give any information or clue on the sequelae of each type?
That is an excellent question, and the answer is that we don't know, because we only did the phenotyping at one time point, at very early on the on the course of ICU admission. So although I said that it does look like that the phenotype stays with the patient throughout their ICU stay, it's not certain, and we certainly need to do more longitudinal studies. Although we haven't collected these inflammatory cytokines, we have collected a lot of other inflammatory biomarker information on all of our patients, and we are analyzing it at the moment. So hopefully in a couple of weeks' time, I can give you some clue whether it is whether we can predict, and at what point of the patient's stay we can predict what's going to happen.
Mm-hmm. Mm-hmm. I also had some questions from the participants to ask you if you were able to give your contact details. If people want some further information on this, would you be willing to share that with us?
Yes. You've got my email address. And
yeah. I can put the.
Yeah, and follow me on Twitter. I am your guest man.
So I am your guest man on Twitter.
Yeah.
And then let me get your email.
I put it in. No, not guessing. Guess.
Oh. Yeah.
I will put it in the chat.
And that's perfect. Thank you. And this is Professor Tamas' email as well for. Wait. There you go. For further contact details. And lastly, since we're a fellowship of medical students as well, if medical students, especially in Cardiff, want to get more involved with this type of research, what should they do? So
I forgot to say that in this paper there are 4 medical students authors. They came to us and did their what is it called now, SCC, the special study component. So they have collected an awful lot of data for us. Hence they are authors on the paper, and they will be authors on many other papers that we will be producing from this from this collaboration. I think what we have been shown in the grant is that we are really welcome medical students, and I can see on the participant list, I can see a couple of names who I know who have been with us before, and hopefully they can attest that they got something out of their modules. I can't promise that I can give everybody a topic, but that is certainly something that you can think about.
That's perfect. Thank you so much. So I'd like to thank you for sharing your research with us and such extensive knowledge about the topic. I'm sure that everyone got a lot out of it. And if I can ask everyone to use your reaction box on Zoom and just click on the applause, the clap button.
Thank you.
That we can have a huge applause for Professor Tamas. This is a way of interacting online, you know.
Thank you very much.
So much, Professor Tamas. I'm going to be posting a feedback form here on the chat. So if everyone can fill that form, that would be very helpful. And also, thank you so much for everyone that's been following Phoenix MedEd's content on social media. And we have a lot of future events coming up, including the conference later this month, which is going to be very interesting. So go on our Facebook page, because the sign-up link for the conference is going to be there, so that you are part of our workshop as well. And I'd just like to also thank Professor Hall, which is the whole organizer of this fellowship, our mom in a way. So, and also the Phoenix MedEd members who've been putting a lot of work into our fellowship and our advertisement on social media and creating content. So I would like to ask everyone to just keep following us, following our project and our fellowship, because a lot of exciting things are coming in the future. So once again, thank you so much, Professor Tamas, and I will let everyone enjoy the rest of their Saturday. Professor Tamas, if you can stay back for a little bit, I'll be very, very thankful. And thank you, everyone. Bye-bye. Enjoy your Saturday.
Thank you. Bye.